So,
All right.
guys, screen. Anyway, let's continue. I wanted to ask Grog about blood grouping with gel cards.
All right. We're back on track and screen recording. So, you want to know about blood grouping using gel cards. Gel card technology, or gel agglutination, is a method for blood typing and cross-matching. It uses microtubes filled with gel and specific reagents, like anti-A, anti-B, or anti-D, to detect red blood cell antigens. You add a sample, centrifuge it, and check for agglutination. Clumping means a positive reaction. It's faster and more sensitive than traditional tube methods. Got a specific part of the process you're curious about?
I don't understand what it is.
No worries. I got you with some tips for blood grouping using gel cards. First, always double check your sample labeling to avoid mix-ups. When adding blood to the gel card, use a precise pipette for accurate volume, usually 10 to 50 microliters, depending on the system. Mix the sample gently but thoroughly with the reagent before centrifugation to ensure even distribution. Stick to the manufacturer's recommended centrifuge speed and time, often around 900-1000 RPM for 9-10 minutes to get clear results. After spinning, read the card immediately under good lighting. Look for clear agglutination patterns, like a line at the top for positive or a pellet at the bottom for negative.
So
Any
basically,
weak
we do this blood grouping with gel cards to see if they're gonna agglutinate or not, to see if they're the same blood type.
Exactly. You nailed it. With gel cards, you're checking if the blood agglutinates, clumps, to confirm blood type compatibility.
And they clump when they are not compatible.
Not quite. Agglutination, or clumping, happens when the blood type matches the reagent in the gel card, not when they're incompatible. For example, if you put blood in a gel card with anti-A reagent and it clumps, it means the blood has A antigens, so it's type A or AB. If there's no clumping, it lacks that antigen, so it's not compatible with that reagent. In cross-matching for transfusions,
Wait. So if it clumps, it means clumping means that it is compatible.
I see where the confusion is. Let's clear it up. In blood grouping with gel cards, clumping, agglutination, means the blood sample has the antigen that matches the reagent in the card. For example, if the card has anti-A and the blood clumps, the blood is type A or AB. It's a positive match for that antigen. However, when you're talking about transfusions or cross-matching, clumping in a cross-match test means the donor blood is incompatible with the recipient because their antibodies are reacting.
Can you summarize what you just said in a sentence? Just so I understand.
In blood grouping with gel cards, clumping shows the blood has the matching antigen for the reagent, like A or B. But in transfusion cross-matching, clumping means the donor and recipient blood are incompatible.
What is transfusion cross matching?
Transfusion cross-matching is a test to check if a donor's blood is compatible with a recipient's blood before a transfusion. It involves mixing the donor's red blood cells with the recipient's plasma in a gel card or other method, and checking for agglutination, clumping. If clumping occurs, it means the recipient's antibodies are reacting to the donor's antigens, so the blood isn't safe to transfuse.
Okay, so what's the difference between transfusion cross matching then and the gel cards, the grouping with gel cards?
All right, let's break it down. Blood grouping with gel cards is about identifying a person's blood type, like A, B, AB, or O, and Rh status, by mixing their blood with reagents, anti-A, anti-B, anti-D, in gel cards, to see if it clumps. Clumping shows the presence of specific antigens. Transfusion cross-matching, on the other hand, checks if a donor's blood is safe for a recipient by mixing the donor's red cells with the recipient's plasma in a gel card or other method. Here, clumping means incompatibility, as the recipient's antibodies are attacking the donor's cells. So, grouping determines blood type. Cross-matching ensures transfusion safety. Clear now?
No, to be honest.
No worries, let's simplify it. Blood grouping with gel cards figures out someone's blood type, like if they're A or O, by testing for antigens with reagents. Clumping means the antigen is there. Cross-matching checks if a donor's blood will work for a specific person by mixing their blood together. Clumping here means it's not safe to transfuse. Grouping is about typing. Cross-matching is about safety for transfusions. Want me to focus on one part of that?
Oh, brother, I'm so confused. I can't lie.
Haha, no stress, bro. Let's make this super simple. Blood grouping with gel cards is like checking someone's ID. It tells you their blood type, A, B, O, etc., by seeing if their blood clumps with certain reagents. Cross-matching is like a safety test. It mixes donor blood with the patient's to see if they'll react badly. Clumping means it's a no-go for transfusion. Grouping equals what's your blood type. Cross-matching equals, is this blood safe to give you? Want to zero in on one of those to clear it up?
So if I have samples and I have A cells and B cells, what blood type is the patient?
Okay, if you have a sample and you're testing it with gel cards, and it clumps with anti-A reagent, A cells, and anti-B reagent, B cells, that means the patient's blood has both A and B antigens. So, the patient's blood type is AB. If it also clumps with anti-D, they're AB positive. If not, AB negative. Does that make sense for your sample?
So what would it take for them to be O positive?
For a patient to be O positive, their blood sample would show no clumping with anti-A or anti-B reagents in the gel cards.
So if it clumps with anti-A, anti-A means antigen A. So if it clumps with antigen A, it means... fucking hell, dude. Help, I don't get it.
Haha, no worries, dude. Let's break it down real easy. If the blood clumps with anti-A in the gel card, it means the blood has A antigens, so it's either type A or AB. For it to be O positive, the blood should not clump with anti-A or anti-B, meaning it has no A or B antigens, just the RH antigen, tested with anti-D, which would clump for positive.
So if it doesn't, if it clumps with anti means antigen, first of all.
All right, let's clear this up. The anti in anti-A or anti-B refers to antibodies in the gel card, not antigens. So
I see. So if the antibody, the antibody A. So we said in the beginning of the podcast that the antigens are things, if they are like labels, and then the antibodies will be. So if we have antigen A in someone's body, then we have antibodies B to look out for other antigens that are not antigen A. So antigen B would clump with antibody B. So if I have anti-A and anti-B clumping, this means that it's that if anti-A and anti-B is clumping, the blood type is AB.
You're getting there, but let's sort out a couple of things to make it crystal clear. Antigens are like labels on red blood cells, A, B, or none for O. Antibodies are in the plasma and attack foreign antigens. In gel card blood grouping, the gel has antibodies like anti-A or anti-B. If the blood clumps with anti-A, it means the blood cells have A antigens. If it clumps with anti-B, it has B antigens. If it clumps with both anti-A and anti-B, the blood has both A and B antigens, so the blood type is AB.
If
You're
it
spot
clumps
on.
with antibody A, it means it has. Why if it clumps with anti-A? Well, then why don't the yes, because with someone that has antigen A doesn't have antibodies A in the body. That would be self-destruction.
Exactly. You're nailing the concept.
So
If
how do we
someone's blood-
decide if it's gonna be positive or minus? Also, tell me about these anti-D clones 1 and 2.
All right, let's tackle this step by step. To determine if blood is positive or negative, you test it with anti-D reagent in a gel card. If it clumps with anti-D, it has the Rh antigen, so it's positive, e.g., A positive or O positive.
Tell me again.
No problem. Let's go over it again. To figure out if blood is positive or negative, you use a gel card with anti-D reagent. If the blood clumps with anti-D, it has the Rh antigen, making it positive, like A positive or O positive. If there's no clumping, it lacks the Rh antigen, so it's negative.
So
like A.
what is this thing with clones then?
All right, let's dive into the anti-D clones. Anti-D clones refer to different monoclonal antibodies used in gel cards to detect the Rhd antigen, which determines if blood is Rh positive or Rh negative. These clones, like clone 1 and clone 2, are specific antibody preparations, e.g., IgM or IgG types, from different cell lines, designed to bind to the D antigen on red blood cells. Some kits use 2 clones to increase accuracy, as they might pick up slight variations in the D antigen, like weak D or partial D. If either clone causes clumping in the gel card, it confirms the presence of the Rhd antigen, meaning Rh positive. Want me to explain how they're used?
I don't get why it becomes positive.
No worries. Let's make it clear why blood is Rh positive. When you test blood with anti-D clones in a gel card, these clones are antibodies that look for the Rhd antigen on red blood cells. If the blood clumps with either clone 1 or clone 2, or both, it means the Rhd antigen is present, so the blood is Rh positive, like O positive or A positive. If there's no clumping with the anti-D clones, the Rhd antigen is absent, so it's Rh negative, like O negative or A negative. The clumping happens because the anti-D antibodies stick to the Rhd antigen, showing it's there. Does that help?
No, I don't understand. I don't understand this D thing, anti-D. So we have an antibody D.
All right, let's simplify this anti-D thing. The Rhd antigen is a protein that some people's red blood cells have and others don't. If you have it, you're Rh positive. If not, you're Rh negative.
And who is
Anti-D.
this rhesus? And why do we have 2 clones of anti-D?
Haha, good questions. The rhesus in Rh comes from early experiments in the 1930s where scientists found this antigen in rhesus monkey blood, and later in humans, so they named it the Rh factor. The Rhd antigen is the main one we test for to see if someone is Rh positive or Rh negative. Now, about the 2 clones of anti-D, these are 2 different lab-made antibodies, like clone 1 and clone 2, that both target the Rhd antigen, but are produced from different cell lines. They might be different types, like IgM or IgG, or sensitive to slight variations in the D antigen, like weak D.
So is it
or
possible for one to be positive and the other anti-D clone to not be?
Yes, it's possible, though rare, for one anti-D clone to show a positive result, clumping, and the other to show a negative, no clumping, in a gel card test. This can happen because the 2 clones, like clone 1 and clone 2, are different monoclonal antibodies that might react differently to certain variants of the Rhd antigen, such as weak D or partial D. Weak D means the RHD antigen is present but in lower amounts, and partial D means the antigen is incomplete. So one clone might
So
detect
it's
it
rare.
while the... Yep, exactly. It's pretty rare. Differences between anti-D clone 1 and clone 2 reacting to the RHD antigen usually only happen with unusual cases like weak D or partial D, where the antigen isn't fully expressed. Most of the time, both clones either clump Rh positive or don't Rh negative together. Want to dive deeper into weak D or move to something else?
So, what blood group is protective for COVID then?
All right, let's dive into studying medicine. Regarding blood groups in COVID-19, some studies suggest blood type O might offer a slight protective effect against severe outcomes. Data from large-scale studies, like one from 23andMe, found type O individuals had a lower chance of testing positive, around 3.2% compared to 3.94.1% for AB, and slightly lower hospitalization rates. Rh negative blood may also show some protection against severe infection, intubation, or death, but the evidence isn't conclusive.
So, why do we even measure the Rh if it's positive or negative? What difference will it make?
Great question. Measuring Rh factor, positive or negative, is crucial in medicine, especially for blood transfusions and pregnancy. The Rh factor refers to the presence, Rh positive, or absence, Rh negative, of the RHD antigen on red blood cells. If an Rh negative person receives Rh positive blood, their immune system can produce antibodies that attack the foreign RHD antigen, causing severe reactions like hemolysis, red blood cell destruction, which can be life-threatening. In pregnancy, if an Rh negative mother carries an Rh positive baby, her body might produce anti-Rh antibodies, potentially harming future pregnancies by attacking the baby's red blood
So,
cells.
if you don't have the antibody, if you have the RHD antigen, it means that you will not have RHD antibodies, correct?
Yes, exactly. If you have the RHD antigen on your red blood cells, meaning you're Rh positive, your body doesn't produce anti-RHD antibodies because it recognizes the RHD antigen as part of itself. Your immune system only makes antibodies against antigens it sees as foreign. So, Rh positive people won't have anti-RHD antibodies naturally. However, an Rh negative person who lacks the RHD antigen can develop anti-RHD antibodies if exposed to Rh positive blood, like during a transfusion or pregnancy. Clearer now?
Yeah.
Wanted
So when I send my blood, I send a sample. What do they exactly do when they test and screen?
All right. When you send a blood sample for testing and screening, like for blood typing or transfusion prep, here's what typically happens in the lab, broken down simply. 1. Blood typing, ABO and RH. They mix your blood with reagents anti-A, anti-B, and anti-D antibodies in gel cards or other methods. If it clumps with anti-A, you have A antigens. Anti-B, B antigens. Both, AB. Neither, O. Clumping with anti-D means Rh positive, no clumping, Rh negative. 2. Antibody screening. They test your plasma for unexpected antibodies, not just anti-A or anti-B, that could react with donor blood. This involves mixing your plasma
And-
with no...
Sorry, continue. Yes, this involves mixing my plasma with.
No worries, let's pick it up. So, in antibody screening, they mix your plasma with known red blood cells that have specific antigens, like a panel of test cells. If your plasma has antibodies against any of those antigens, it'll cause clumping, showing you have unexpected antibodies that could cause transfusion reactions. 3. Cross-matching. If you're getting a transfusion, they mix your plasma with the donor's red blood cells to ensure no reaction occurs. No clumping means the donor blood is safe. 4. Additional tests if needed. For donations or specific cases, they might screen for diseases like HIV, hepatitis, or check for rare antigens. This all ensures your blood type is identified and any transfusion is safe. Want me to zoom in on any part of this?
This is good. Let me ask you now, what is anti-globulin test, Coombs test?
Awesome. Glad you're vibing with this. The anti-globulin test, also called the Coombs test, is a lab procedure used to detect antibodies that are bound to red blood cells or floating in plasma, which can cause issues like transfusion reactions or hemolytic disease. There are two main types. 1. Direct Coombs test. This checks if antibodies or complement proteins are already attached to your red blood cells, often used to diagnose autoimmune hemolytic anemia or reactions from mismatched transfusions. They mix your red cells with anti-human globulin, Coombs reagent. Clumping means antibodies are present on the cells. 2. Indirect Coombs test. This looks for free antibodies in your plasma that could react with red blood cells, used in blood typing, cross-matching, or prenatal screening. They mix your plasma with test red cells, add Coombs reagent, and check for clumping. It's key for ensuring safe transfusions and monitoring pregnancy risks. Want more details on how it's done or why it matters?
So Coombs test, basically they will see if already I have clumping in my blood.
You're on the right track. The Coombs test, specifically the direct Coombs test, checks if your red blood cells already have antibodies or complement proteins stuck to them, which would cause clumping or hemolysis. They take your red blood cells, add Coombs reagent, anti-human globulin, and look for clumping. If it clumps, it means antibodies are already bound to your red cells, like an autoimmune hemolytic anemia or after a bad transfusion reaction. The indirect Coombs test, on the other hand, checks your plasma for free antibodies that could cause clumping if mixed with certain red blood cells, like in cross-matching or prenatal testing.
I'm confused too. Can you summarize a bit? Maybe speak slightly faster too.
All right, let's simplify and speed it up. The Coombs test detects antibodies causing blood cell issues. Direct Coombs checks if antibodies are stuck to your red blood cells. Clumping means yes, like in autoimmune diseases or transfusion reactions. Indirect Coombs tests your plasma for free antibodies that could react with red cells, used for safe transfusions or pregnancy screening. Clearer now? Want to dive deeper?
So what is this anti-immunoglobulin antibody that they use to agglutinate the red cells? What does even globulin mean, dude? You didn't even explain.
Haha, my bad, dude. Let's clear this up quick. Globulin refers to a group of proteins in your blood, including antibodies, also called immunoglobulins, which are made by your immune system to fight foreign stuff like antigens. The anti-human globulin, AHG antibody, used in the Coombs test, is a lab-made antibody, often from animals like rabbits, designed to bind to human antibodies or complement proteins that might be on or around your red blood cells. In the direct Coombs test, if your red cells have human antibodies stuck to them, adding AHG makes them clump, agglutinate, because it links those antibodies together, making the reaction visible. In the indirect Coombs test, AHG is added after mixing your plasma with test red cells to see if your plasma's antibodies stuck to those cells, causing clumping if they did.
So the direct one tells us if the red cells are coated with the antibody.
Yet, exactly. The direct Coombs test checks if your red blood cells are already coated with antibodies or complement proteins. They add anti-human globulin, Coombs reagent, and if there's clumping, it means your red cells have antibodies stuck to them, like in autoimmune hemolytic anemia or transfusion reactions. Nailed it. Want to dive into the
okay, let's take a break from the transfusion and let's talk a bit about the drug distribution. So, what is drug distribution, and how did it occur?
Alright, cool. Let's switch gears to drug distribution. Drug distribution is the process by which a drug spreads from the bloodstream to tissues and organs in the body after it's absorbed, like from a pill or injection. Once a drug enters your blood, it gets carried around and delivered to different areas, like your brain, liver, or muscles, depending on the drug's properties. How it happens depends on a few key factors. 1. Blood flow. Organs with high blood flow, like the heart, liver, and kidneys, get the drug faster. 2. Protein binding. Drugs often bind to plasma proteins, like albumin. Only the unbound free drug can move into tissues. 3. Tissue permeability. Some tissues, like the brain, have barriers, e.g., blood-brain barrier, that limit drug entry, unless the drug is fat-soluble. 4. Volume of distribution. This is a measure of how widely a drug spreads. Low means it stays in the blood. High means it's in tissues. For example, a drug like ibuprofen spreads to muscles and joints, while some chemotherapy drugs target specific organs.
So
It's driven by-
when I have higher drug concentration in the tissues, will it go back to the systemic circulation? And if yes, why?
Great question. Yes, a drug can move back from the tissues to the systemic circulation, and this happens because of a process called redistribution. When a drug's concentration is higher in the tissues than in the blood, it can diffuse back into the bloodstream due to a concentration gradient. Drugs naturally move from areas of higher concentration to lower concentration. This is driven by a few factors. 1. Blood flow. As blood flows through tissues, it picks up the drug, especially if the drug isn't tightly bound to tissue proteins. 2. Binding
Keep
dynamics.
your answers short, dude. 2-3 sentences. You are going in monologues. Okay. So, and what is the interstitial fluid, and how does this play a role with this kind of back and forth from the vessels to the tissues?
My bad. I'll keep it tight. Interstitial fluid is the liquid surrounding cells and tissues, acting as a middleman between blood vessels and cells. Drugs move from blood to interstitial fluid to reach tissues, and back to blood when tissue concentration is higher.
Yeah, what
driven by-
is interstitial fluid?
Interstitial fluid
Yes.
is the fluid that fills this. All right, to continue.
No, sorry.
Interstitial
tell me.
fluid is the liquid surrounding. My bad. Interstitial fluid is the watery liquid between cells and tissues, surrounding them. It helps drugs move from blood vessels to tissues and back, acting as a bridge for drug diffusion.
So it's the in between tissues and vessels.
Exactly.
And what does,
Interstitial fluid is
what
the
does
in-between.
stitial, what does stitial mean? What is this stitium? Where does this come from?
All right. I think you might be referring to stichial and possibly interstitium. So let me clarify both briefly. Stichial isn't a medical term. It historically refers to a kind of coarse, hairy wool, like Kemp's sheep, per some old texts, and doesn't relate to medicine.
No, I mean, explain to me the etymology, the semantics, the semiotics of interstitium.
word interstitium comes from Latin inter, between, and sistere, to stand or place, meaning the space or gap between structures. In medicine, it refers to the fluid-filled spaces between cells and tissues, like a network of compartments supporting drug movement or immune function.
Okay, so in a sentence or two, remember the next 100 questions I'll ask you. Keep your answers short, dude. We all have a short attention span. We are not robots. So, what's going on? Do drugs bind to albumin in the plasma?
Yep, many drugs bind to albumin in plasma, which acts like a carrier. Only unbound, free drugs are active or can move into tissues.
Explain this a bit more, please.
Drugs bind to albumin, a protein in plasma, to travel safely in blood. Only the unbound, free fraction of the drug can leave blood to act on tissues or be metabolized. All right, back to medicine. Drugs bind to albumin, a plasma protein, to hitch a ride in the blood, reducing their metabolism or excretion. Only the free, unbound drug can exit blood to act on tissues or get processed. So albumin binding affects a drug's effectiveness and duration.
So this always happens, and where exactly is albumin anyway?
Most drugs bind to albumin to some extent, depending on their chemical properties. Albumin is a protein found in blood plasma, produced by the liver, and it circulates in the bloodstream.
Okay. And tell us some drugs like this, warfarin or aspirin or ibuprofen, heparin, furosemide. Also, what does furosemide do?
Ibuprofen, aspirin, heparin, and furosemide all bind to albumin in plasma to varying degrees, with ibuprofen and aspirin binding strongly, heparin moderately, and furosemide less so. Furosemide is a diuretic that increases urine output to treat fluid buildup in conditions like heart failure or edema.
So what about heroin? Does heroin bind to albumin?
Yes, heroin and its metabolites like morphine does bind to albumin in plasma, though less strongly than drugs like ibuprofen. This binding helps it circulate before being metabolized or distributed to tissues.
So can you talk a bit about the body fluid compartments? So we have intracellular and extracellular, and then that's breaking down to plasma and interstitial. Can you explain this more?
Body fluid compartments are split into intracellular, fluid inside cells, about 60% of total body water, and extracellular, fluid outside cells, about 40%. Extracellular breaks down into plasma, fluid in blood vessels, about 20% of extracellular, and interstitial, fluid between cells, about 80% of extracellular. Drugs move through these, mainly plasma and interstitial, to reach tissues.
Would you agree that what we just did was categorical thinking?
Yeah, I'd say so. Breaking down body fluid compartments into intracellular, extracellular, plasma, and interstitial is a classic example of categorical thinking, organizing complex info into clear, distinct groups to understand it better. Want to dive deeper into this?
What other types of thinking exist?
Besides categorical thinking, there's analytical thinking, breaking problems into parts, like solving a puzzle. Creative thinking, generating new ideas or solutions. Critical thinking, evaluating evidence and arguments. And systems thinking, seeing how parts connect in a whole, like an ecosystem. Each helps tackle different challenges. Want to explore one of these?
Any more?
Yup, a few more. Abstract thinking, grasping concepts beyond the concrete, like metaphors. Concrete thinking, focusing on literal, tangible details. Divergent thinking, brainstorming multiple possibilities. And convergent thinking, finding one correct solution. Each suits different tasks. Want to zoom in on any?
No, so one last question. What are different types of logic?
Types of logic include deductive logic, general rules to specific conclusions, like all men are mortal, Socrates is a man, so Socrates is mortal. Inductive logic, specific observations to general conclusions, like the sun rose daily, so it'll rise tomorrow. Abductive logic, best explanation from incomplete data, like diagnosing illness. And fuzzy logic, handling partial truths, used in AI. Want a quick example of one?
Yes, give me an example of fuzzy logic. What about, like, do we have modal logic or no?
Fuzzy logic example. A thermostat uses partial truths, room is somewhat warm versus hot, to adjust heat gradually, not just on, off. Modal logic, which deals with necessity and possibility, e.g., it might rain versus it must rain, is another type, often used in philosophy or computer science. Want me to expand on either?
Yes, and give us more types of logic. For instance, what about things like in chemistry? We have like two maybe not contradicting, but like complementary theories when it comes to what an acid and what a base is, if you could explain this. Or in physics, we have quantum and classical mechanics, and they also kind of contradict each other. So what type of logic is this if we want both of them to coexist?
All right, let's dive into more types of logic and address how complementary or seemingly contradictory theories, like in chemistry, acid-base theories, or physics, quantum versus classical mechanics, fit into logical frameworks. Beyond deductive, inductive, abductive, fuzzy, and modal logic, here are a few more. Dialectical logic, resolving contradictions through synthesis, like Hegel's ideas. Non-classical logic, allowing more than true-false, e.g., many-valued logic. And paraconsistent logic, handling contradictions without breaking the system, useful in complex scenarios. Now, about chemistry's acid-base theories, like Arrhenius, Bronsted-Lowry, and Lewis, or physics's quantum and classical mechanics, these don't rely on contradictory logic, but rather complementary perspectives, best explained by contextual or pluralistic logic. For example, Bronsted-Lowry defines acids as proton donors and bases as acceptors, while Lewis focuses on electron pair donation. Both coexist because they apply in different contexts, like aqueous solutions versus broader chemical reactions. In physics, quantum mechanics, governing subatomic scales, and classical mechanics, macroscopic scales, seem to clash, but they coexist under a pragmatic or contextual logic, where each is valid in its domain, e.g., quantum for
So you
atoms.
said pluralistic logic.
Yeah, pluralistic logic fits here. It allows multiple frameworks, like acid-based theories in chemistry, or quantum and classical mechanics in
Okay,
physics.
what about the other two you mentioned? You mentioned Hegel and you mentioned something else in the beginning, one or two other types.
Cool, let's cover those. I mentioned dialectical logic, Hegel's approach, where contradictions like thesis and antithesis resolve into a synthesis, e.g., opposing ideas merging into a new understanding. And non-classical logic, like many-valued logic, where truth isn't just true-false, but can have degrees, e.g., something can be partly true. Also, paraconsistent logic, handling contradictions without the system collapsing, like accepting quantum and classical mechanics differences in specific contexts. Want an example of one in action?
I want to ask what the difference is from this paraconsistent and the second one you gave, because you mentioned before the example with the thermostat of being somewhat hot. What's the difference of that type of logic? Of fuzzy logic and all these kind of in between binary and kind of, yeah, non-binary.
Great catch. The difference between paraconsistent logic and fuzzy logic, the thermostat example. is subtle but key. Fuzzy logic deals with degrees of truth, allowing values between true and false, e.g., a room is 70% warm, not just hot or cold, like a thermostat adjusting gradually. Paraconsistent logic, however, handles contradictions directly, allowing conflicting statements to coexist without breaking the system, e.g., quantum mechanics saying a particle is both wave and particle without forcing one to be false. Fuzzy logic is about partial truths. Paraconsistent logic is about tolerating contradictions. Want a quick example to nail it down?
No, this is good. Let's go back to medicine. So tell us about the apparent volume of distribution.
Alright, back to medicine. The apparent volume of distribution, VD, is a measure of how widely a drug spreads in the body, calculated as the amount of drug in the body divided by its plasma concentration. A high VD, e.g. for drugs like digoxin, means the drug distributes extensively into tissues, while a low VD, e.g. for warfarin, means it stays mostly in plasma.
Pretty straightforward. And so VD equals dose over plasma concentration.
Exactly, that's it. VD equals the dose of the drug divided by its plasma concentration, showing how much it spreads into tissues versus staying in the blood.
So let's say I dose 20 milligrams and the plasma concentration is 10 milligrams per liter. What does this mean?
If you dose 20 milligrams of a drug and the plasma concentration is 10 milligrams per liter, the apparent volume of distribution, VD, is 20 milligrams divided by 10 milligrams per liter equals 2 liters. This low VD suggests the drug mostly stays in the plasma rather than spreading widely into tissues.
Because only 50% went to the tissues.
Not quite. VD doesn't directly tell you the percentage that went to tissues, but a VD of 2 liters, like in your example, suggests the drug is concentrated more in plasma than distributed to tissues.
Why more? I had 20 milligrams total and 10 are in the blood, in the plasma, so I guess the other 10 should be in the tissues or in the interstitial fluid.
You're right to question that. Let's clarify. If you dose 20 milligrams and measure 10 milligrams per liter in plasma, the VD is 2 liters, 20 milligrams divided by 10 milligrams per liter. This doesn't mean exactly 10 milligrams is in plasma and 10 milligrams in tissues. VD is a theoretical volume showing how the drug behaves. A low VD, 2 liters, suggests the drug is mostly in plasma and not widely distributed to tissues, possibly due to high plasma protein binding, like to albumin, or limited tissue penetration. The other 10 milligrams could be in interstitial fluid or tissues, but the low VD indicates it's not extensively stored outside plasma. Want to dive into what affects this distribution?
So what would be a high VD?
A high volume of distribution, VD, is typically above 0.6 liters per kilogram, or roughly 42 liters in an average adult, indicating the drug spreads extensively into tissues. For example, drugs like digoxin or chloroquine have VD values of 500 to 700 liters, meaning they heavily concentrate in tissues rather than plasma.
So this is volume of distribution to the tissues, right?
Not exactly. The volume of distribution, VD, isn't just to tissues. It's a theoretical volume that shows how a drug is distributed across the entire body, including plasma, interstitial fluid, and tissues. A high VD, e.g.
And so what happens to the rest of it? Does it get digested in the stomach? Does it get destroyed in the liver?
The volume of distribution, VD, only describes how a drug spreads in the body, not what happens to it afterward. The drug that's not in plasma for high VD drugs is mostly in tissues or interstitial fluid, but over time, it can be metabolized, often in the liver, or excreted via kidneys.
But
Not
wait,
typ-
didn't you say that volume distribution means that the volume distribution in plasma, in interstitial fluid, or in extracellular or whatever?
My bad if that was confusing. The volume of distribution, VD, is a theoretical measure of how a drug spreads across all body compartments: plasma, interstitial fluid, intracellular fluid, and tissues, not just one. A high VD means more drug is in tissues or interstitial fluid compared to plasma, but it doesn't specify where exactly, just the overall extent of distribution. Want to clarify with an example?
Okay, we'll come back to this in a bit. Let's go back to the blood transfusion. So we talk about this Coombs test. Let's talk a bit more about reasons. We said about when it's minus, when it's positive. And is it IgG?
All right, back to blood transfusions and RH. The RH factor is positive if the RhD antigen is on your red blood cells, negative if it's not. Tested via gel cards or Coombs test. Anti-RhD antibodies, which cause issues in Rh negative people exposed to Rh positive blood, are typically IgG, not IgM, because IgG can cross the placenta and cause hemolytic disease in newborns. Want to dive into Rh testing?
So
or
how does
IG?
the IgG I don't understand how it relates to RhD, if you can tell me in a sentence or two.
IgG antibodies in an Rh negative person can form against the RhD antigen after exposure to Rh positive blood, causing reactions in transfusions or pregnancy. These IgG antibodies are detected in tests like the Coombs test to ensure safe blood matching.
Wait, why in Rh negative? Rh negative, they don't have antigens, but they do have antibodies. That's why. I don't get it.
No worries, let's clear it up. Rh negative people lack the RhD antigen on their red blood cells, so they don't naturally have anti-RhD antibodies. However, if they're exposed to Rh positive blood, e.g., via transfusion or pregnancy, their immune system can produce IgG anti-RhD antibodies, which can cause reactions like hemolysis or hemolytic disease of the newborn in future exposures. That's why we test for these antibodies using the Coombs test. Makes sense now?
No.
What? All right, no stress. Want to stick with Rh and IgG or switch to another
No, I want to
transfusion?
understand what you said.
Got it. Let's make it super clear. Rh negative people don't have the RhD antigen on their red blood cells and don't naturally have anti-RhD antibodies. If they get Rh positive blood via transfusion or pregnancy, their body can make IgG anti-RhD antibodies, which can attack Rh positive blood later, causing issues. The Coombs test checks for these antibodies to prevent reactions. Clearer now? Want an example?
So if they are given Rh positive blood, they will make antibodies, IgG antibodies.
Exactly. If an Rh negative person gets Rh positive blood, their immune system sees the RhD antigen as foreign and produces IgG anti-RhD antibodies
So in
to
the
fight it.
future, if they are given more Rh positive, it will clump and they will burst and they will have all these problems that we talked about.
Yep, you got it. If an Rh negative person who already has IgG anti-RHD antibodies from a prior exposure gets more Rh positive blood, those antibodies will attack the Rh positive red blood cells, causing clumping, hemolysis, cell bursting, and potentially severe transfusion reactions or complications. That's why we screen with the Coombs test to avoid this.
So hemolytic disease of the newborn, for instance, is when the child has like plus and the mom has a minus.
Exactly. Hemolytic disease of the newborn happens when an Rh negative mom, no RHD antigen, carries an Rh positive baby with RHD antigen, and her IgG anti-RHD antibodies cross the placenta, attacking the baby's red blood cells, causing hemolysis. This usually occurs in second or later pregnancies after initial sensitization. Want more on how it's prevented?
Yeah, sure.
Cool. Hemolytic disease of the newborn is prevented by giving Rh negative moms, RhoGAM, anti-RHD immunoglobulin, around 28 weeks of pregnancy and after delivery if the baby is Rh positive. RhoGAM neutralizes any fetal Rh positive red blood cells in the mom's blood, stopping her from making IgG anti-RHD antibodies that could harm future babies. Want details
I
on
don't
how
get it. So this stops her from making anti what? Does it work the other way around, or is it only if the mom is plus and the baby is minus?
All right, let's clarify. RhoGAM is given to Rh negative moms to stop them from making IgG anti-RHD antibodies when they carry an Rh positive baby. It works by clearing any Rh positive fetal red blood cells from the mom's blood before her immune system reacts, preventing sensitization.
And what's this thing that they give to the moms so they don't produce these positive anti-D antibodies or whatever?
That thing is RhoGAM, a shot of anti-RHD immunoglobulin given to Rh negative moms. It neutralizes Rh positive fetal red blood cells in the mom's bloodstream.
What is this anti-RHD immunoglobulin?
Anti-RHD immunoglobulin, like RhoGAM, is a lab-made antibody, mostly IgG, that targets RHD antigens on red blood cells. Given to Rh negative moms, it binds to any Rh positive fetal red blood cells in their blood, removing them before the mom's immune system makes its own anti-RHD antibodies, preventing complications like hemolytic disease of the newborn. Want more on how it's made?
So it will bind this antibody to the antigens, and will this not create problems to the mom because it will create this bursting of the red cells?
Good question. RhoGAM, anti-RHD immunoglobulin, binds to Rh positive fetal red blood cells in the Rh negative mom's blood and quickly clears them via the spleen, preventing her immune system from making its own anti-RHD antibodies. This process doesn't cause significant red cell bursting, hemolysis, in the mom because the amount of fetal cells is small and the clearance is controlled, avoiding major issues. Want to know more about the safety of RhoGAM?
I don't get why it's safe.
Fair enough. RhoGAM is safe because it targets only the small amount of Rh positive fetal red blood cells that
So it's
might
not
leak into the
enough to create this clumping.
Exactly. The amount of Rh positive fetal red blood cells in the mom's blood is usually so small that when RhoGAM binds to them, it doesn't cause significant clumping or hemolysis. RhoGAM quickly clears these cells via the spleen, preventing the mom's immune system from reacting and keeping her safe. Want to explore more about RhoGAM's
Yeah,
mechanism?
this makes sense. Okay, let's go back to this volume of distribution because I still don't understand it. So if we have a high volume, I understand what it means. I just don't understand the measurement that it's dose over plasma conc.
All right,
Well, if it's
let's
high,
nail.
it means that we gave a high dose and at the same time we had a small plasma concentration. So if we had a small plasma concentration, it means that a lot of it is in the tissues.
You're spot on. A high volume of distribution, VD, means you gave a dose and got a low plasma concentration, indicating most of the drug is in tissues, not plasma. VD equals sign, dose, divide plasma concentration. So a high VD, e.g. 500 liters, shows the drug spreads widely into tissues or interstitial fluid. Want to clarify the math with an example?
I want to ask you about VD. So if we have like a high VD, do we need a larger dose or no?
A high VD means the drug spreads extensively into tissues, so you often need a larger initial loading dose to achieve the desired plasma concentration. However, it depends on the drug's target site and
But
clearance rate.
why do we care anyway about the plasma concentration? I thought what we care about is like the tissue concentration. Because usually the site of action isn't it the tissue?
You're right. The tissue concentration often matters most, since that's usually the drug's site of action. But we measure plasma concentration because it's easier to sample and reflects how much drug is available to reach tissues. A high VD means more drug.
Yeah.
Cool. Take digoxin, a drug with a high VD, 500 to 600 liters, because it distributes widely into tissues like the heart. You need a larger loading dose, example, 1 to 1.5 milligrams, to quickly reach effective plasma levels, compared to a drug like warfarin with low VD that stays in plasma. Want to explore another drug?
Yeah, but I don't get it why we need a larger dose. Why? Okay, yeah, but my question is why do we need anyway more of the drug to be in the plasma?
Great question. For drugs with high VD, like digoxin, a larger dose is needed because much of the drug leaves the plasma to spread into tissues, leaving less in the blood to do its job. You need enough drug in plasma initially to ensure therapeutic levels reach the target tissues before it disperses widely.
I don't get
Want
it.
to? No worries. Let's simplify. A high VD means the drug spreads a lot into tissues, so less stays in plasma. You need a larger dose to ensure enough drug stays in plasma to be effective and reach tissues before it all scatters. Want to try a specific drug example to clear it up?
Yeah. Yeah, I don't get why we need a high plasma concentration.
Okay, let's make it clear. For a drug with high VD, like digoxin, you need a higher initial dose to get enough in the plasma because the drug quickly spreads to tissues, reducing plasma levels. Sufficient plasma concentration ensures enough drug reaches the target, like the heart for digoxin, before it disperses too much. Want a numerical example?
I don't get your answer, to be honest.
My bad. Let's try again simply. With a high VD drug, like digoxin, it spreads fast into tissues, so plasma levels drop quickly. You need a bigger dose to start with enough in plasma to hit the target organ effectively before it spreads out. Clearer, or want to focus
So
on one part?
basically, maybe I want digoxin to act. What does digoxin do? Where does it act?
Digoxin helps the heart pump stronger and controls heart rate.
So digoxin acts at the heart, but it spreads to the calves, which we don't need it, basically.
Exactly. Digoxin targets the heart to improve its pumping and rate, but with its high VD, 500 to 600 liters, it spreads widely to tissues like muscles or fat, example, calves, where it's not needed.
And
That's why
what variables play a role in volume distribution?
volume of distribution, VD, is influenced by drug properties, like fat solubility or protein binding to albumin. Patient factors, body fat, muscle mass, or fluid status, and blood flow to tissues. For example, fat-soluble drugs have higher VD in obese patients, while high albumin binding lowers VD. Want to explore one factor?
No, that makes sense. That makes sense. So if we have a low VD, does this mean that we have a highly protein-bound drug?
Yes, exactly. A low VD often means the drug is highly bound to plasma proteins like albumin, so it stays mostly in the blood rather than spreading to tissues. Examples include warfarin or heparin. Want to compare a
I don't
specific
get it, dude. I don't get it, because you use the word plasma versus tissues, whereas before you weren't making this distinction between plasma and tissues. You said that distribution included both, how it's distributed in both plasma and tissues. Why did you do this?
My bad for the confusion, dude. Volume of distribution VD measures how a drug spreads across all body compartments, including plasma and tissues. But when we say low VD, it means the drug stays mostly in plasma, blood, due to high protein binding, like to albumin, and doesn't spread much
Well,
to
why
tissues.
doesn't it have high protein binding in the calves too?
Good question. Protein binding, like to albumin, mainly happens in plasma because that's where albumin is abundant, circulating in the blood. Tissues like the calves have less albumin or other binding proteins, so drugs with high plasma protein binding, example warfarin, stay in the blood rather than binding or accumulating in tissues. Want to look at a drug example?
I don't get the reason.
No stress. Let's clarify. Albumin, the main protein drugs bind to, is mostly in plasma, blood, not in tissues like the calves. So drugs with high protein binding stay in the blood.
So it
Tissues.
won't move because it sticks to the... But why does it stick to the region that it's supposed to act on?
All right, let's clear this up.
Or will it eventually circulate where it needs to be without going outside the circulation to the tissues? But that also means that it won't go to the target organ either as much.
You're getting at a key point. A drug with high plasma protein binding, low VD, stays mostly in the blood, bound to proteins like albumin, and doesn't spread much to tissues, including the target organ. It still reaches the target organ via circulation, but in smaller amounts, as only the free, unbound drug can leave the blood to act, which happens gradually. Want an example with a specific drug?
I didn't get what you just said, and yes, I do want an example.
My bad. Let's simplify with an example. Warfarin, a drug with low VD, 0.14 liters per kilogram, binds tightly to albumin in plasma, so most of it stays in the blood. Only a small amount of free, unbound warfarin circulates to its target, the liver, to prevent clotting. But it gets there slowly without spreading much to other tissues like muscles. Clearer now?
Well, how
Want
does
another?
it actually pass to the liver but not to other tissues? What in its structure gives this magical ability?
Warfarin reaches the liver primarily because the liver gets a lot of blood flow via the hepatic artery and portal vein. So even the small, free, unbound fraction in plasma gets delivered there efficiently. Its structure, highly polar and protein bound, means it doesn't easily diffuse into other tissues like muscles,
Alright.
which have less.
So let me ask you about the bag of donated blood then. So we have a bag of donated blood. There's red cells inside, there's plasma inside. What other things do we have? We have coagulation factors, we have gamma globulins. What are gamma globulins? We have platelets. Explain what platelets are.
bag of donated blood, you have red blood cells, carry oxygen, plasma, liquid with proteins, coagulation factors, help clotting. Gamma globulins are antibodies, mostly IgG and IgM, in plasma that fight infections. Platelets are small cell fragments in blood that clump together to form clots and stop bleeding. Want details on any of these?
All of them.
All right, let's break down what's in a bag of donated blood. Red blood cells carry oxygen to tissues using hemoglobin. Plasma, the liquid part, contains water, electrolytes, and proteins like albumin. Coagulation factors are proteins XZ, factors 8, 9, that trigger clotting to stop bleeding. Gamma globulins are antibodies, mostly IgG, IgM, that fight infections. Platelets are tiny cell fragments that clump to form clots and seal wounds.
I thought those were antiglobulins, not gamma globulins.
My bad for the mix-up. You're right to question gamma globulins and antiglobulins are different. Gamma globulins are a class of plasma proteins, mainly antibodies, like IgG, IgM, in donated blood, that help fight infections. Antiglobulin, like in the Coombs test, is a lab-made antibody used to detect antibodies on red blood cells, not a component of donated blood. Want to dive deeper
So
into gamma
antiglobulin is artificially made?
Yup, exactly. Antiglobulin, used in tests like the Coombs test, is artificially made, often from animals or cell lines, to detect human antibodies or complement proteins on red blood cells.
So what is apheresis?
Apheresis is a process that collects specific blood components, like platelets, plasma, or white blood cells, from a donor's blood using a machine that separates them and returns the rest to the donor. It's used to get high yields of one component, like platelets for cancer patients, without taking whole blood. Want more on how it works?
Yes.
Cool. In apheresis, a donor's blood is drawn into a machine that spins it, centrifugation, to separate components based on density red cells, plasma, platelets, or white cells. The desired component, XZ, platelets, is collected into a bag, while the remaining blood is returned to the donor through the same needle, often with saline to replace volume. Want details on a specific type, like platelet apheresis?
So blood leaves the patient and then it comes back.
Yup, exactly. In apheresis, blood is drawn from the donor, a machine separates out the needed component, like platelets or plasma, and the rest of the blood is returned to the donor in a continuous loop.
Just to remove something that we don't want.
Not quite. Apheresis isn't about removing something harmful from the donor's blood, but about collecting specific components, like platelets or plasma, for donation to help patients. The donor's blood is returned minus the collected part, but it's not to purify their blood.
Why do we give it back to the donor?
We give the remaining blood back to the donor in apheresis to keep them healthy, as only a specific component, like platelets or plasma, is needed for donation, not the whole blood.
But, so has anyone died from donating too much blood?
Deaths from blood donation are extremely rare and usually not from donating too much blood, as strict guidelines limit donation frequency and volume. XZ, 450 to 500 milliliters every 8 weeks. Most issues, like fainting from low blood pressure, are minor and resolve quickly. But very rarely, coincidental health events, like undiagnosed heart conditions, might occur post-donation, though not directly caused by blood loss.
But surely there's been at least one incident where someone donated too much blood.
There aren't well-documented cases of someone dying directly from donating too much blood in a single, regulated session, as blood banks follow strict FDA and WHO
Yeah, but
guidelines.
I know, but surely there is one scandal or something.
You're digging for the juicy stuff, huh? There aren't clear, well-documented cases of deaths directly from overdonation in regulated settings due to strict controls. But scandals related to blood donation often involve contaminated blood.
Alright, never mind. Okay, so when do we give a blood transfusion? So we have an acute blood loss, for instance. Maybe obstetric or from trauma. Yeah, tell us.
Blood transfusions are given when someone loses significant blood or can't make enough, like in acute blood loss from trauma, EGSI, car accidents, obstetric complications, EGSI, postpartum hemorrhage, or surgeries. They're also used for severe anemia, bleeding disorders, or conditions like cancer, where blood production is low.
Tell us more about the anemia then. Hemoglobinopathies, bone marrow failures. What types of anemia? Aplastic anemia, myelodysplasia? Tell us.
All right, let's dive into anemia and transfusions. Anemia, low red blood cell count, or hemoglobin, can require transfusions in severe cases. Key types include 1. Hemoglobinopathies, EGSI, sickle cell disease, thalassemia, where defective hemoglobin causes red cell breakdown. Transfusions help replace faulty cells. 2. Aplastic anemia, where bone marrow fails to produce blood cells, often needing frequent transfusions. 3. Myodysplastic syndromes, where bone marrow makes abnormal cells, leading to low hemoglobin. Transfusions boost oxygen delivery. Transfusions are used when hemoglobin drops critically, EGSI, less than 7 grams per decimeter, or symptoms like fatigue or heart strain are severe. Want details on one type or treatment specifics?
Oh, this is good enough. And so do we have different types of transfusion depending on what blood components we give?
Yep, exactly. Different types of transfusions depend on the blood component given. Red blood cells, for anemia or blood loss. Platelets, for bleeding or low platelet counts. Plasma, for clotting disorders or shock. And cryosymptotin, rich in clotting factors, like fibrinogen. Each targets a specific need. Want to zoom in on one type?
What about cell salvage and autologous?
Cell salvage and autologous transfusions are special types. Cell salvage collects a patient's own blood during surgery, EGSI, from bleeding, filters it, and transfuses it back to them, reducing donor blood needs. Autologous transfusion involves a patient donating their own blood weeks before surgery for later use, ensuring compatibility
It's
and minimizing.
genius, dude. Why don't more people do this?
Cell salvage and autologous transfusions are awesome, but aren't used everywhere because of limitations. Cell salvage requires specialized equipment and trained staff, not always available in smaller hospitals, and it's only practical in surgeries with significant blood loss. Autologous donation needs advanced planning, healthy patients with good hemoglobin, and isn't suitable for emergencies or those with certain conditions. Want more on their challenges?
No, it's all good. And
Sweet.
so let's talk about blood availability then. So, yeah.
All right, let's talk blood availability. Blood supply depends on donations, but shortages happen due to low donor turnout, seasonal dips, holidays, disasters, or specific needs, like rare blood types. Blood banks prioritize based on urgency, EGSI, trauma, surgeries, and screen for safety, but demand often outstrips supply, especially for O negative or platelets. Want details on improving availability?
So tell me about, let's say it's O negative, or let's say if it's fully screened cross-matched, or if it's group compatible.
All right, let's break this this down. O negative blood is the universal donor type, used in emergencies when there's no time for cross-matching, as it lacks A, B, and Rhd antigens, minimizing reaction risks. Prenatal cross-matching involves testing a pregnant woman's blood against donor blood to ensure compatibility, especially for Rh negative moms, to prevent hemolytic disease. Group-compatible transfusions match donor and recipient ABO and Rh types, EXI, A positive to A positive, but still require cross-matching to confirm no antibody reactions.
So basically, if it's really immediate, we will give O negative. If we only have like 10 minutes, we will do group compatible, and then if we have more time, we'll do a full screening.
Spot on. For immediate emergencies, O negative is given since it's universal and safe without testing. If you've got a bit more time, like 10 minutes, group-compatible blood, matching ABO and Rh, is used, often with a quick cross-match. With more time, a full cross-match and antibody screening ensure maximum safety. Want to dig into
the
one?
difference of group compatible and full screening?
Group-compatible transfusion matches the donor and recipient's ABO and Rh blood types, EXI, A positive to A positive, but may skip full antibody screening in urgent cases, relying on a quick cross-match. Full screening includes a complete cross-match and antibody screen to detect any unexpected
So what
antibodies.
is the difference between a complete one and an incomplete partial one?
A complete cross-match tests the recipient's plasma against the donor's red blood cells, including an antibody screen and incubation to detect all possible incompatibilities, taking about 45 minutes. An incomplete or partial cross-match, like in urgent cases, skips some steps, like extended incubation or full antibody screening, using just ABO Rh compatibility and a quick test, done in 10 to
What
15.
else do you use besides ABO and Rh?
Besides ABO and Rh, a complete cross-match checks for other antigens and antibodies, like KEL, Duffy, or KID blood group systems, using the recipient's
What the
plasma.
fuck's KEL and Duffy?
Fair reaction. KEL, Duffy, and KID are blood group systems, like ABO or Rh, with antigens on red blood cells that can trigger immune reactions if mismatched in transfusions. They're tested in a complete cross-match to ensure compatibility beyond ABO.
Are they more rare then?
Yeah, KEL, Duffy, and KID antigens are less common than ABO or Rh issues, but still critical. They vary by population. KEL is more common in Europeans,
How do
7.9.
we call it Duffy? How do we spell it?
Duffy is spelled Duffy. It's named after the patient where the antigen was first identified, part of a blood group system tested in
So
cross-matching.
we have FYA, FYB, FYO.
You're diving deep into the Duffy blood group. It's actually FYA, FYB, and FY null, not FY0, referring to antigens in the Duffy system. FYA and FYB are common variants. FY null, no Duffy antigen, is more frequent in some African populations, offering malaria resistance. These are tested in cross-matching to avoid transfusion reactions. Want to explore their role in transfusions or
that
malaria?
makes sense. Okay, so what are some hazards then? So what are some major ABO incompatibilities and what might happen? We might die, we might have renal failure. Why would we have renal failure? Disseminated intravascular coagulation, explain.
Major ABO incompatibilities happen when mismatched blood, EXI, giving A blood to an O recipient, causes the recipient's antibodies to attack donor red blood cells, leading to hemolysis, cell bursting. This can cause acute hemolytic transfusion reaction, with symptoms like fever, chills, hypotension, and potentially fatal complications like renal failure or disseminated invascular coagulation, DIC. Renal failure occurs because hemoglobin from destroyed red cells clogs kidney tubules, and immune complexes trigger inflammation.
What about taco?
It seems you might be referring to the HH blood group system, not HACO.
No,
As there's no
transfusion associated circulatory overload.
My bad. Thanks for clarifying. Transfusion-associated circulatory overload, TACO, is a transfusion complication where too much blood volume, given too quickly, overwhelms the heart and lungs, causing fluid buildup, pulmonary edema. Symptoms include shortness of breath, high blood pressure, and heart strain, potentially leading to heart failure in at-risk patients like the elderly or those with heart issues. Want details on prevention or treatment?
That makes sense.
Glad it clicked. Want to dive into another transfusion complication or switch to a different medical topic?
I want to ask about iron overload too.
All right, let's talk iron overload from transfusions. Repeated blood transfusions, like in thalassemia or sickle cell disease, can cause iron overload because each unit of red blood cells adds about 250 milligrams of iron, which the body can't easily excrete. This excess iron builds up in organs like the liver, heart, and pancreas, potentially causing damage, heart failure, or diabetes if untreated. Want to know about symptoms or
Yeah, that
treatments
makes
like
sense.
chelation therapy?
Alright guys, thanks for watching and peace.